Well, good afternoon, everyone, and thanks for participating in our added March webinar today. My name is Angela Boyle. I'm the Executive Director of the Nursing Institute for Healthcare Design, or NIHD. I'm happy to see a lot of new names on the list for today. NIHD has a mission to engage and integrate clinical expertise into the planning and design of healthcare environments. We welcome you all to join our membership as we work to shape the future of healthcare environments through clinical and interprofessional leadership, education, and advocacy. Speaking today, we have one of our industry partners, Paladin Healthcare, presenting how to plan and design for the what-if scenario. This presentation, shared by Paladin Healthcare President Gary Schindele, will discuss how to implement designs from master planning to immediate fixes in both dedicated healthcare and non-traditional care environments, an extremely timely and relevant topic today especially. A few housekeeping items. As you know, there's a huge influx of individuals using services such as Zoom, so we hope there are no glitches here today. If for some reason your connection is lost, we will be sharing a recording of this webinar with attendees and all NIHD members. All attendees will remain on mute for the duration of the webinar. We will have time for questions at the end. So if you do have a question, feel free to type that in at any time, and we'll be reading those to our speaker at the end. You can use the Q&A or the chat feature. As you can see up on the screen, this webinar offers EDAC CEUs and AIA CEUs. The EDAC CEU form and course number will be emailed to all attendees for your records since the EDAC is self-submit. We also ask that you complete a short survey linked in the follow-up email. There is space to provide your AIA membership number at the bottom of this survey if you require a certificate of completion. So at this time, I will pass it over to our speaker, Gary. Thank you.
Good afternoon or good morning, depending where you are this morning. Thank you, Angela, for allowing us to add this program into your webinar schedule, given the timeliness of it. Look forward to some good questions and some good dialogue with everybody on the call here on the program here today. So a couple of just housekeeping things that need to get through. There we go. Copyright material, all AA stuff, course evaluations, of course. So a little bit about my background. I've been continuously certified for 45 years as an EMT and firefighter and former paramedic, all of that in volunteer service. So it's kind of been parallel to what I've been doing in business. Been involved in literally hundreds of healthcare facility projects around the world for the last 40 years. I'm also certified in hazardous material operations and tactical combat casualty care, which is the active shooter stuff. I'm currently a member of the Central Florida Disaster Medical Coalition, and we stand up field hospitals and in the environment around here too. So just a little bit of my clinical background. So our training objectives today are that we're going to talk about the importance of emergency management and how the architectural and design community integrates with the clinical team players, and maybe has more of a major role than you had thought in terms of supporting the response by clinical personnel. And what emergency preparedness has to do with the physical infrastructure. I mean, there's a lot of it we've talked about in the past, but I think given the current state of events, the A&D community has to take a little bit of a sharper look, along with some of our regulatory agencies, about how to best prepare for something like this, should God forbid it happen again. We discuss some basic design options which will support effective surge response, not only now but in the future. And I'm going to also just glance on the new concept of the crime prevention through environmental design. It's something you should be aware of. Came out in light of all the active shooter stuff and hospital shootings. I'm just going to touch on that, and we can provide further resources. There's a dedicated program just for that, but I just wanted to make you aware of that. And then, what can we do now to solve some of the immediate nature of the situation? Well, let's define mass casualty incident first. The definition formally is that any situation where the number of injured needing care exceeds the resources available to perform care. We usually think about that as isolated incidents, hazmat incidents, we've had, some bigger incidents, but that nobody really thinks that it's going to be as broad-based as we've had it today. It can be an unforeseen situation which threatens your employees, not only at your workplace, so your customers or the public. It can be one which disrupts or shut down your operations or causes physical or environmental damage. Again, this is a presentation, by the way, I put together many, many years before we had our a little COVID-19 pandemic, but it's again something to think about. So it can really be any level of event. Doesn't have to be a worldwide global event, or it can be any hospital in the U.S. on any afternoon on any given day. Most hospitals in the U.S. are overflowed. They deal with surge populations on a daily basis. The picture in the upper right there is a New York City Health and Hospitals Corporation facility. I took that picture on a Tuesday afternoon at 2 o'clock, and between every curtain there are 3 patients stacked in, and there's one across the foot of just about every bay. So there's a 4-to-1 patient to bed ratio, and that's just on a regular day in New York City. So these things happen pretty much all the time. And again, surge management is something that sometimes we deny ourselves the conversation because we just don't think it's going to happen. But let's think more in the reality of the situation. So our friend Benjamin Franklin said, "By failing to prepare, you are preparing to fail." And this goes through and has been proven in a lot of different scenarios, from hurricanes and earthquakes and terrorist attacks. But it's time that we really talk about, getting prepared for events, large and small, at our local community healthcare facilities. And what preparedness means is that it is really the managerial function charged with creating the framework within which facilities and communities reduce the vulnerability to hazards and cope with disasters. It's known as your vision or your plan. Every business has a business continuity plan. And I think, hospitals are bound by also the federal funding to have these plans. Unfortunately, a lot of hospitals have 3 binders in the admin that lay out their plan, and once a year they pull them out, dust them off, and they can tell Joint Commission that they've gone through their plan. But again, it's meant to promote safer, less vulnerable communities and facilities, and the capacity to cope with hazards and disasters. That's the whole idea of that. So common misconceptions about emergency management, emergency planning. Most people think emergencies are short-lived. They happen, you see them on the news, and life goes on, and unless you're intimately involved with the event, it pretty much goes away. Orlando was the highlight with Pulse shooting several years ago. It was in the national news for several days, and then it went away, but it impacted Central Florida community for months, and even after several years, it's still in the news down here. So most emergencies are not short-lived. The not in my backyard syndrome. I won't ever have to deal with an emergency like this where I live. Well, I think the pandemic here just proved that wrong on all levels. It's something that we don't know what's going to happen next or where it's going to happen. The variables of emergency medicine have taught us that a long time ago. There are a lot of emergencies I can't prepare for. It's true, but a little bit preparedness for some of the basics is a whole lot better than no preparedness. So let's at least start at the very beginning and talk about what we can do at a very fundamental level to be prepared. Now, the next one we'll deal with a little bit more in depth later. What I want to do does not mean meet code. That's one of my biggest bugaboos right now with Joint Commission, and any of the clinicians that are on this will understand and certainly respect the fact that when Joint Commission comes in, everybody freaks out, and no matter what we want to do as a preparedness standpoint, if it doesn't fit in their box, we can't do it. And then preparing takes too much time. It's one of those things where, I don't have time to do that because it's not going to happen in my backyard. So these are a lot of the misconceptions that we deal with. So I added this slide last year. We held a mass casualty drill as part of the Central Florida Disaster Coalition early last year. It involved 40 healthcare facilities, 60 municipal, county, state, and federal agencies. We had 1,500 victims, volunteer high school kids throughout 5 counties. And the premise of that was a coordinated bombing and active shooter assault throughout Central Florida region. In addition, there was a ricin chemical attack with a potential ricin release into the public water supply. I was an evaluator at one of the facilities for that. It went very well, but all we heard a lot of is that, well, this could never happen here. This is such a hypothetical thing. Why are we spending all this resource? Well, fast forward to Easter of last year. Again, we've out of the news. It didn't happen in our backyard. But, all of a sudden we had several hundred dead, several thousand wounded. We had over 100 bombs detonated throughout the region, including 87 alone at the bus station. And the next thing you know, an event like we practiced for actually did happen somewhere. So this is why we practice. This is why we get involved. And this is why we do what we're supposed to do in the emergency management field. So, and here we are today in 2020, who would have thunk it a year ago, to think that something like this was going to happen here, wasn't even in the realm of what I would consider consciousness. So we're in a whole new level of preparedness and a lot of unknowns here. So from an A&D community, what I would suggest you do is start the conversation with your client base, and from a clinical team, if you're listening, then insist that your architectural partners talk about what is a hazard vulnerability assessment. Every hospital has pretty much done that. They've done the risk assessments, but it's not a conversation that you usually have on the front end of the design process. And we talk about, risk assessments, term used to describe the overall process and method where you identify hazards and risks. And in some communities, it may be a chemical plant, and what happens if there's an explosion and you have several hundred people downwind all of a sudden coming in with respiratory care issues. That's one risk assessment in certain communities. So, these are the conversations we want to have because it can happen just about anywhere. Anybody who's got an interstate running through it. Now, some hazards can't be eliminated. This was an aerial view of the tornadoes that came through Florida in 1998. I happened to have been the first one on the scene of this with my partner in a brush truck and a commercial light trailer, and spent about 6 hours in the middle of the night combing through all of this mess. At the end, we had 8 dead and 32 injured. But again, there's nothing you can do to prepare for a tornado in the middle of the night. It's something you just have to be trained in responding to. But the hospitals around here, again, we're not set up, and this tornado happened to have gone all through Central Florida, and was one of the largest mass casualty events we'd ever seen in the county areas. So at any time when a capacity is overburdened, there's going to be compromise, a lot of the basics. And the goal of preparing and training for the worst case scenario is not to eliminate the compromise, but reduce and manage as much of the risk of the caregiver and the patient. And that's what we're hearing a lot of right now, is the caregiver's risk factor of not having the PPE equipment, not having N95 masks. So we go back to Maslow's hierarchy of needs, and we apply that to healthcare. And we go back to really something that we should be doing when we design any hospital. This is the priority list that I think we ought to come back to, and that is caregiver safety. Should be the first and foremost priority of any design that we do. Having the right tools, the right equipment, the right medicines. And once we go up there, all of the secondary issues of visibility, communication, efficiency, privacy, all very important. But, the things that we tend to put most focus on in the A&D community, and we see that in healthcare design magazines, we're looking at ease of use, comfort, prettiness. At the end of the day, from a clinician standpoint, those are probably the least things that we want to worry about, because we need to be effective and we need to be safe ourselves as clinicians. So the goal should be to proactively manage compromise and reactively deal with it. Life safety should always be given the highest priority for caregivers first, and then patients. If a caregiver is compromised, it'll only further reduce the ability to adequately manage patients. I mean, right now in New York City alone, there's over 300 firefighters that are down in quarantine with the COVID-19. And it's going to affect staffing in a lot of other departments, not only from the EMS and fire standpoint, but also law enforcement. We've also known that a lot of hospital staff have already contracted it. So, hospital safety, caregiver safety should be the first and foremost priority. One of the things that every hospital has to have, as far as its Joint Commission stuff, is a command center. And as you're going through the design, I don't know how many of you asked the hospital of what your plans for command center is, but I will tell you that the need for command centers are getting more and more important. And for the A&D community listening in here, that picture on the upper right is far better than that picture on the bottom right. We're more and more activity, more and more personnel involved. That picture on the right was the one that I happened to have been at in the last mass casualty drill. When it was full, there were about 15 people in that room, mostly standing room only. Very ineffective, and we had a lot of issues in terms of flow of people coming in and communicating. So, talk about your command center. Where is it? Think about demountable walls or collapsing walls that you can expand rooms and actually create something that's more effective. Marker boards, documentation from the incident start by minute. Literally on a minute-by-minute basis, things have to be documented. And sometimes they're documented electronically, which is great, but there has to be a backup. So, allow for for documentation in that room. In this case, we didn't have enough marker boards. We had to take pictures of the panels, and we had to erase them and start over again. And this thing was a 5-hour duration event. And just again, lesson learned, there was just not enough room for physical documentation. So some of the other things in terms of emergency notification to think about when you're talking about preparing for an emergency. Mass notification of employees and community partners must be included. So have some means of telecom or digital communication available. The ability to reach by radio. One of the things also, you know, we're designing all these lead-lined walls that we put in these CT rooms and radiology rooms. But, you know, when they have an emergency, they pull out their VHF radios and their walkie-talkies. And one of the things that we found in the hospital I was at is that you couldn't get with that walkie-talkie past about 4 or 5 hallways down, and you lost the signal because we had radiology in between, and then we had all of these other things that you're building up that's blocking the signal. So our recommendation there was to put in-house repeaters. The same thing we put in fire trucks to get longer distances. It's easy to do on the front end, and this way you can actually repeat the signal within the facility. So, you know, think about that, of how they're going to communicate if power goes down, if they're reliant on the radios. It's just something we learned through that exercise. Redundant call-in features if the internet down. If something really goes bad, the internet is down, how else are we going to communicate with the outside world? Then employee support system. But the other thing we learned is to ensure the overhead paging, because in this particular scenario, we had ricin potentially in the water system, and we had to shut down all water consumption in the hospital and go to bottled water. And how do you do that? Does the EOC have a reliable connection to the operator or paging? Can they take over overhead paging from the EOC? And those are all kind of things that you want to look at and making sure that you've got continuity and communication. Decon, something that we're not having to do necessarily right now. However, we're doing more isolation, but if you have a radiological, biohazard, or chemical event, you know, you want to be able to put a tent outside, but at that you need to have water flow. You know, where are you going to put your tent? Is your water flow back into the ER? Is it flowing away from the hospital? And what kind of space do you need to get your folks in and out of the gear effectively? So containment of the water is not a consideration, because right now doing recommendations, the part beyond the patient is going to be sufficient back into the natural spillways and waterways. Throughput versus parking. This is something that they learned at Orlando Health during the Pulse nightclub shooting. They were smart enough to throughput all of the patients to the ER and park them somewhere else. And luckily it happened in the middle of the night, and they used pre-op and post-op areas. But they didn't actually treat anybody in the ER, so they did not bottleneck the ER. I mean, this thing was so fast because the event happened about 3 blocks from the hospital. There was no full warning, but they were very smart in the way that they managed their patients. So patients who are not critical and can be adequately managed in a non-critical or non-traditional setting can be quickly moved through to create room for more critical patients. And again, have a discussion about how are you going to do that? How are you going to throughput your patients rather than park them somewhere? And talk about reunification with family members. I mean, that's a big thing that ultimately swamped Orlando Health, because everybody showed up there wanting to know where their loved one was, and they wound up having an issue with. The need for rapid deployment of medical gas systems, especially if you have something that's going to be a respiratory issue. You know, we want to do rapid expansion of med gases without compromising the infrastructure and being able to take patient rooms up to an ICU level. There's technology out there that allows you to do that successfully in a very quick manner. There's some new technology out there for bulk gas delivery. It's something that's being discussed right now because there's a shortage of oxygen tanks. And you cannot power a ventilator very easily off of these small tanks, and large tanks are few and far between. So again, look for non-traditional point-of-care locations where there's now some high-volume gas delivery systems available that can bring enough oxygen to support a ventilated patient for a longer period of time. So again, technology is advancing pretty quickly as a byproduct of the need we have right now, and just keep an eye out for a lot of that stuff that's becoming available. Again, cross-contamination. The biggest thing we have right now is managing stuff at the bedside effectively so we don't contaminate our caregivers. And the picture on the right is a real picture taken in a field hospital where the monitor was just hung in the same stretcher that patients lie on, and everybody made contact with it, everybody coughed on it and sneezed on it, and then they moved that monitor to another patient. So that's a lousy way to run a railroad, and that's why we have a lot of the cross-contamination issues that we do. So we have to manage the stuff that is a byproduct of patient care as best we can to protect our caregivers. And the regulatory and the A&D components of our industry have to at some point realize that in a crisis situation, aesthetics don't matter. I mean, when you get a patient that's going to need stuff and trauma surgery and all the other things that, the pretty is no longer as important as the practical. And, somewhere we need to find a balance between that coming up the road. Though. Flexibility with space is key in planning the response. So I'm going to throw some what if scenarios out at you. So what if the hospital main lobby was designed by purpose to become an ER overflow space? What if the cafeteria was designed on purpose as a walking wounded gathering space, or where patients could reconnect with worried loved ones? What if we made that in the master planning of a new facility part of the mindset of how we can do these things should something like this happen again? Access to PPE and basic equipment at the disposal of hazardous sharps. The picture on the right, it took the University of Chicago. It took that at about 10 o'clock in the morning. That's the way their ER looks every single day, with dedicated beds numbered. But what's not there? There is no PPE, there's no sharps, there's no gloves, there's no soap, there's no foam. And they're treating these patients, and they have absolutely, complete risk of cross-contaminating. HIPAA goes out the window. But that's the way a lot of hospitals in the United States function every single day. So again, think about in your planning, how are we going to manage the inevitable overflow that pretty much every hospital gets on an everyday basis? It's just something that we have to come to grips with on the front end, because if you build it, they will come. What if we put gas outlets and pre-position them behind artwork in the lobby? Now envision the deployment of mobile equipment stations to these areas, and they can just plug and play. They can plug in electrical outlets, they can plug into gas outlets, and now you can create triage stations, on demand. Problem is, Joint Commission doesn't let us put outlets in the lobby, and that's again an issue and an obstacle to proper planning. And we need at some point to lobby them and get together and say, look, how can we best maintain a footing to respond to mass casualty events with stuff like this and being creative. Wayfinding. This is another problem during surge. The common way of doing wayfinding right now. We've got cones in the janitor's closet. It works great if the guy's there who knows where they are. We're 3 o'clock on a weekend shift and you're floating nurses in, they may not know where it is. So it's not the optimal location. So I would challenge you to start thinking about what the alternates, because what happens in the crisis is that we've got ambulances coming in from all over different parts of the region, delivering patients to hospitals where the medics may not be familiar with, where the trauma room is, where the waiting room is, and where all the other aspects are. So it creates a bottleneck as they come into the ER. Usually on a big event, they'll stage ambulances, and again, they'll come from all over the place, and they'll just be ready to go, and they'll deliver to the next closest hospital that happens to be there, regardless of where they're originally based out of. So let's consider about lighting as an aid to directing traffic. What if we could integrate LED lighting into our designs and dedicate it to an emergency incident so we can intuitively show the way to various designated triage areas? With green lighting for low acuity, yellow lighting for moderate to severe, and red for critical. Everybody's used to doing emergency lighting. We've been doing it in airplanes for a long, long time. If we just incorporated LEDs, which is so easy to do now in our hallways and in some of the rooms we want, we just tell ambulances to follow the green line to the green patients, and the yellow line to the yellow patients, and the red line to the red patients. It's not hard to do, again, if we think about that on the front end of the design process. Again, this is something that's been I've been advocating for many, many years, but what if public venue projects or government facilities were mandated that the facility be designed with the deliberate intent to support public safety role in time of crisis? So every stadium gets built, every venue, every basketball arena, every football stadium, should be built with a pre-planned way to stage medical supplies, number one, but manage patients, again, number two. It can be done with lighting, triage areas. You think back to the Ariana Grande Manchester United Kingdom concert bombing. They had an event in the stadium, and there was nothing there in the stadium that could manage the patients that were created. Las Vegas shooting the same way. And after Hurricane Katrina, they used the Superdome, and after in New Orleans, and After Hurricane Harvey, the convention center in Houston was used as a offsite. And here we are in 2020, and guess what they're thinking about? They're now talking about buying up hotels and using stadiums and the Javits Convention Center in New York. The only problem is that they're not prepared for that. So, what do we do? How do we change our programming and our mindset to start thinking about, as we build new venues, what we can do to be better prepared? I'll tell you, the movement of stuff to a non-traditional space, the logistics are a nightmare. Number one, it takes the availability of manpower. And if your manpower is compromised, as we are now, you may not have that manpower. And you need access to the venue. So if you have a broken infrastructure after a hurricane or earthquake, or limited manpower and first responders are ill, then you're already slowed your process down. Right? This is at the Orlando Citrus Bowl Camping World Stadium. We set up a 54-bed field hospital for the Electric Daisy Carnival every year. It takes days to move in and set up under ideal conditions, right? But what if power generation and air conditioning units had the capacity to plug into the building? We're working with the U.S. Army on a replacement hospital right now. Their parking lot is pre-planned with connections for water and for electrical services, knowing full well that they are expecting a mass casualty setup for that facility at some point. And they have all of their connections pre-piped as they're building that new hospital. Why don't we do that in every hospital? Why isn't every parking lot pre-planned to set up a tent? This is a tent that we do at Disney. This is what they do. This is a critical care tent for the Disney Marathon series. I work a couple of these a year. Yes, they use old recliners and lounge chairs from resorts as the beds, but this is in a parking lot at Disney. And if we did that at a hospital and just had pre-piped electrical and gas systems and water systems, it would be a lot easier than having to run them from a remote location. So again, thinking about that to pre-plan for future events, it's not hard to do on the front end of the process. And it's been done before. After the hurricane in Puerto Rico, the DMAT teams down there actually set up the basketball arena in San Juan as a field hospital, and they operated out of there for several months. And the benefit they had there is they didn't have to put the roof on their tents, but they set up their tents up, and they set that up because the local hospitals were devastated, and they actually used the arena as a general hospital. The general for months after the hurricane. So it's been done before, but again, it just wasn't planned for at the time. The other question is on a what if scenario. What if hospitals, and again, the clinicians that are listening, you'll appreciate this. Why are we throwing all the good stuff out? This is stuff that I still have in my trauma bag, and that angiocath expired 35 years ago, but if I got to correct somebody with it, it'll work. Stuff that's expired 2 or 3 or 4 or 5 years, still good. An endotracheal tube that expires tomorrow is still good 5 years from now. We do that in EMS. We hoard equipment for the mass casualty incidents, but it's usually localized. And it's just something that, we need to start thinking about at a hospital. The national stockpile that everybody's talking about is very, very old. I was talking to one of my ER managers yesterday, and he had gotten some of the national stockpile N95 masks, 20 years old. He said, as soon as you put them on and try to fit them, the material cracked because it was that old. So we shouldn't be relying at a local level on the national stockpile of stuff. We need to start considering what we're going to do locally to manage our own caregivers at our own facilities at the time of need. And this again goes back to regulatory agencies at all levels, local, state, and national, Joint Commission specifically, should put in place an immediate waiver for all facilities and first responder agencies regarding expired inventory. Again, an endotracheal tube or saline solution expired last week is still good for several years. When Joint Commission comes around, we scour up all the closets and anything expired, and we send annually millions of dollars worth of consumables to underdeveloped countries who use them for years. We don't throw anything out. That stuff gets shipped off, and we take it as a tax write-off. So my feeling is that we should stockpile expired inventory for 5 years locally in all our facilities that are easily deployable, and at every point of care location. And this way we can take care of our own and not have to worry about federal aid coming in with stuff that's 20 years old, and it's my soapbox. So caregivers got to defend their case. Any A&D community has to help. Technology exists to create these spaces and manage these patients. Flexibility, adaptability, expandability, These are cornerstones. I mean, we see that written in Healthcare Design Magazine all the time. We see the words written, but you know, it's one of those things. How do we actually apply it? What do we do to actually make that a real thing? And we have to address the reality of non-traditional areas in patient care. These events are not going away. I'm just going to touch on the CP-TED real quick. It's just a multidisciplinary approach to deterring criminal behavior. CPT strategies rely on the ability to influence offender decisions that precede criminal acts. And it's been proven that the proper design and effective use of the built environment can lead to a reduction in the fear and incidence of crime and improve the quality of life. The physical guidance of people coming and going from a space using appropriate designed entrances, fencing, landscaping, and lighting direct people where you want them to go. And this also plays in a natural disaster or a major disaster, because you want to be able to guide the people coming to the facility in a way that you control them rather than just flooding in at every entrance. There's been a number of hospital shooting increases. That's been by a couple of studies. And again, there's a separate program on just the CP-TED, but the basic principles are natural surveillance, natural access control, territorial reinforcement, and the maintenance of cameras and fencing and landscaping that goes around it. So if anybody's interested in more of that, maybe you can put that on the survey, and I can get you the name of some of the law enforcement officers that I know that teach the program. So emergency preparedness in the A&D community, essential elements. Work with your design teams during the construction projects. Start having a discussion about master planning or at the master planning cycle about where you're going to put your command center, how are you going to flow your people, how are you going to throughput them, where you're going to rejoin families. All of these things, regardless of the size of the incident, are things that have to be discussed at some point. You know, identify the hazards and risk assessment. You know, there's a hospital here in Orlando that's got a train track running right through the middle of the campus, and every night they put, you know, highly flammable freight trains go right through the campus. And I can tell you that their emergency preparedness plan looks a little different than most of the hospital plans in the rest of the country. That's just the way it is. What are the capabilities and resources in-house? Do you have your own decon teams? Do you have to call in resources from fire rescue? Where do they set up the tents? Is there a designated space for that? Learn the emergency plan and procedures. The A&D community really needs to discuss on the front end the plan, integrate the facility plan with the community plan, and then conduct trainings and you know, for A&D folks, attend drills with them. If they're doing a big drill, somebody from your firm ought to probably be there and just watch. And they'll let you do that. They'll gladly have you there, and I think it lends a lot of credibility to the way you're going to design the unit. And then public relations, you know, if you're doing this, there's always good news when you plan ahead. And then conduct drills and exercises also in your own offices. Once we get back to some level of normalcy, if you all haven't already conducted active shooter drills or emergency evacuation drills in your offices, please do so, because it's, you know, that's the kind of thing that will save time. And when you save time, you save lives. And think outside of the box and ultimately ask yourself, what if? Because if you're not thinking about that what if scenario, then you're missing something. So I think I'm in still a good time here, 48 minutes. So we're very glad to be your partner in all of this. This ultimately concludes the presentation here. And if you got any questions, I'm all ears.
Thanks, Gary. Okay, at this time, we will open up the Q&A and the chat feature. So if you have any questions for our speaker, feel free to send them now. We'll give you a minute to send them in. Just a reminder, at this time, we are recording this webinar. And again, we'll be sending a follow-up survey. So if you do have follow-up questions for Gary, you can see the email is up on the screen there, or you can send in your questions via the survey, and I'll make sure he gets that in your contact information. Any questions?
If not, you can reach out to me, and I'm more than happy to chat with you.
I have a question for you, Gary, here. A couple of them coming in.
Okay.
The first one, what type of innovations are you seeing as hospitals are partnering with hotels, dormitories, et cetera, for the current pandemic? Are you seeing any?
That one is still up in the air. I think what we'll see is contingency plans and partnerships growing because, and we've been in a discussion actually with a lot of folks offshore in other countries where they're taking housing from sports venues and stuff and trying to convert them into quarantine housing. The question is, what level of patient are you going to put there? Are you going to put those that are mildly symptomatic there? Are you going to put those who actually need medical gases and monitoring? So that question is being discussed at length, but I don't know that there's an answer to that yet. But it certainly is going to stay in the discussion realm as new dormitories and new housing is built in the vicinity of healthcare facilities.
Thanks. I have 4 other questions that have come in. So 5 other questions. We'll just go through the list and get through as many as we can. From Roxanne Butler, I wonder whether there will be some rethinking of JIT or just-in-time delivery for supply chain with future hospital designs.
Yeah, I think they're going to have to get, to the whole process improvement and lean issue. I mean, it's not so much that is having bulk, because remember, there's still regular patients in these hospitals. Yes, they've canceled elective surgeries. And yes, they've done a lot to reduce the patient load. Actually, I had some interesting feedback from, again, another one of my ER directors. This virus has scared off the frequent flyers. So they're actually seeing a reduced census in their ERs because all of their regulars are not coming in. So which is on the flip side, actually not a bad thing in terms of freeing up space. But as far as par leveling inventories, that's my point about stockpiling expired goods. They still need to manage the costs. They still need to manage the supply side of it. And hoarding is never a good idea, but taking a responsible look at managing expired inventory and keeping that on hand is not going to take away from the regular hospital part inventory. And that's really what's been happening. They've stripped everybody who's needing it elsewhere in the facility to manage their COVID-19 patients, which does a disservice to everybody else that's in the hospital. So I think the stockpile of emergency supplies is the answer to that.
I'm going to jump questions because I have a question that directly kind of comes after what you just said. Why are the governments and hospitals throwing away expired supplies when they can still be used? Isn't someone informing them that they can still be used?
That is a joint commission thing. That is a regulatory thing. The expiration dates on stuff is an FDA compliant requirement. Somebody has to put an expiration date on something, and a lot of it is almost a built-in reuse because all of the companies know that when it's expired, they have to go buy a new one. It's a false sense of security. There are a lot of medicines and that are good for 5 years, 10 years afterwards, and that are still more than effective. But mostly it's the soft goods. I mean, if you got an endotracheal tube, like I said, or an IV saline solution or something basic like that, they're good for years and years afterwards, and it's been proven. There's no downside to keeping them. So, and that's where I think together we as an industry need to push back against Joint Commission and say, hey, wait a minute, guys, we really need to change the way you're regulating us. In fact, you should mandate that we save expired inventory for 5 years. And that's just something nobody's given thought to until this incident here, and hopefully that'll be a positive byproduct of this very negative event.
Here's another question. Like you mentioned, and we have experienced, many regulatory agencies do not allow planning for surge capacity. How do we handle this in the future? And maybe you've kind of addressed this, but I thought I'd just ask the question.
I think it's going to be an industry event. I think it's something that we have to go back to not only the state agencies, but also, the talk about it at a federal level that, we've proven now the need for surge. I mean, and let me back up. We've proven the need for surge capacity requirements for many incidents, whether it's active shooters or whether it's hurricanes or earthquakes or brush fires in California. I mean, the need for preparedness has been there, but it's not been on such a global scale. So maybe this will trigger the dialogue that's been needed for a really long time to say, look, surge capacity management has to be on the front end of the planning and has to be approved at a regulatory level. So if anybody here is listening that's got a tie into state agencies, regulatory agencies, you know, and the same thing goes to, you know, large conferences. Let's start talking about this at healthcare design and all the other conferences we go to at the AIA level. You know, let the AIA start pushing this back to regulatory agencies and say, hey guys, you know, we have a responsibility to look at this thing seriously.
Mm-hmm. So what can we do for existing facilities?
Well, there are a number of things we can do. You know, from a technology standpoint, the biggest thing right now, I think, is to sort through, you know, what avenues are out there for let's put it, let me back up. What are the patient loads that are really needing hospitalization? We're already seeing in New York, the hospitalization numbers go down. I think what they're figuring out up there is that not every person with COVID-19 has to be in a hospital. So I think we need to filter that out. And I think the more experience we have with this, we are figuring that out, that, you know, maybe the symptoms will go away and maybe not everybody needs to be in a hospital. The other thing is, you know, again, looking at technology that's available to ramp up alternate site locations without compromise. And again, you know, whether it's the freestanding gas delivery systems or, you know, freestanding carts or something that go into these spaces that can bring effective PPE for the caregiver first and foremost, and then sufficient supplies to manage whatever that the patients need to manage. So again, it's a fluid new territory for most facilities, but there are tools and ways to manage those things safely and non-invasively without a lot of construction. We don't need to build new hospitals. We just need to adapt what we have with the technology that we have, and we can manage more than efficiently, I think, everything that's coming down the pike. We kind of built a hospital in 2 weeks because they had to. They didn't have a convention center or a school auditorium or a hospital that they could just park patients into.
I have 4 other questions, so let's keep going. Do you know if there is any repository out there that is collecting all the amazing ideas that hospitals are implementing today? That's a great question. Do you know if there's any agencies? Yeah.
I don't know that anybody has the bandwidth right now to collect that. I do know that in discussion with the Army Corps of Engineers and the DoD, they are doing a lot of that as well, and they're implementing a lot of things on their side. Fairly regular communication with them. So they are taking a lot of this to heart, and I think you'll see some recommendations coming out of the federal level because of them documenting some of the opportunities that are being created. I think there's going to be a long debrief period out of this. I think we'll see a lot of symposiums and a lot of discussion on the after action reports on this to try to figure out what's best practice. But again, I think this is where AIA needs to come up with some guidelines, you know, that push down to the architectural community and design community. I think Joint Commission needs to establish some guidelines. I mean, and take all of the stuff that we've gotten and create some new standards specifically for this.
So going forward, is there an effort to work with supply chain to do inventory management regarding expiration dates and housing of supplies?
I hope so. I hope, again, you know, the problem with expiration dates is that Joint Commission will ding you if you have expired goods. And until Joint Commission stops penalizing hospitals for keeping, you know, expired supplies, then there's no incentive to keep them. Now I'm hoping that supply chain will figure out a way that an offsite warehouse, maybe to store that and not tell anybody. But it's gonna have to take a system-wide effort to start having that dialogue. You know, and we haven't even gotten to talk to supply chain managers at this point. They're just doing everything they can to get anything. I mean, we're short on gas fittings. I mean, forget about, everybody's building ventilators. There's actually a shortage on fittings for ventilators because a lot of them are made in China. So, you know, you think about the ripple effect on this, that the layers that this is impacting is so far beyond what we hear on a day-to-day basis. But there will be a lot of discussion, I think, with supply chain when these conditions are.
I have a couple of questions regarding the storage of equipment.
Mhm.
So I'll ask these two questions now together. At some point, there will be excess equipment all over the country that will not be used, and hospitals not having capacity to store that. What will become of that equipment?
Again, I think that, and you're right, there's a lot of stuff being deployed. Nobody's going to need 40,000 ventilators in 3 weeks from now or 4 weeks from now. So, I think that at some point, that's where the federal government needs to regionally deploy that and stockpile that so it can be quickly deployed. There are certain things that obviously coming from this event that will be done, ramped up, manufactured. I think hospitals need to have a base supply. They should be able to take care of their own needs for, a week or 10 days without reinforcements. And, whether it's renting a warehouse somewhere that's climate controlled, or adding on temporary buildings. I mean, we're working with someone right now that does temporary, actually they're permanent buildings, but they're collapsible and they can be put up remotely. They actually provided most of the clinics in Puerto Rico after the hurricane that set up and to replace the stadium hospital. But there's a lot of alternatives out there that can be created to take what they're getting and keep that and store it. Somebody's paying for it. Throwing it away shouldn't be an option. And again, we're so on the front end of the curve on this. It's a great question, and I think needs to be addressed locally.
Can you briefly explain what products you are offering now for our surge population management?
We have a number of solutions from freestanding cart systems that are basically mobile intensive care stations that incorporate the oxygen delivery system in there as well, that can be parked in an auditorium, in a cafeteria, in a tent. We have gas expansion systems that can convert patient rooms into ICUs non-invasively and in a matter of minutes and not hours without touching the zone valves or any construction. Feel free to email me or call me. I don't want to take time to the rest of the people here on that, but we have a number of tools that we have available to us. And a lot of that, by the way, is being modified even sometimes on a daily basis as we're being able to develop and access some new technologies, some of our companies. So we literally are adding every day something new to the mix based on the feedback that we get.
Thanks, Gary. I have one more open question here, and if I don't see any come in, we will end the presentation for today. So last question. If Joint Commission typically has been a barrier to designing options in the foyers and common areas, how will their requirements be altered, and who is providing these recommendations to them?
I mean, I think that's where the Nursing Institute for Health Design is a great vehicle to do that. I think that it's organization like yours that can, pull people like this on this call together and start petitioning them from the local level. I mean, every hospital has a Joint Commission rep that they have an avenue to go up to, and again, AIA as a powerful lobbying tool. I think that the architectural community, should take an active role in putting design standards together and recommendations that the AIA can publish. And once we get a level of push at organizations at that strength and level, I think the Joint Commission will have to look at things a little differently. I mean, it's bureaucracy. It's we all have to deal with it. But the more people start singing the song, the more people are going to listen and chime in. And it's got to start somewhere. And unfortunately, it took this type of an event. But I'm hoping that people will wake up and really start pushing at every level. But I think the NIHD is a great way to start. The Center for Health Design, I think, is a great place to start. I mean, it's all evidence-based stuff. They should start putting this out. So together we can fix it, I think.
We agree. So I don't see any other questions. If you do have questions, again, a reminder, you can submit those in the survey, or again, contact Gary directly, and his team would be happy to answer those questions for you. Just a reminder, we'd love you to continue following NIHD. We're sharing resources from our members and our partners, Healthcare Design Magazine, various conferences. So we definitely encourage you to follow along with us. If you have any resources, we'd love to have them and share them as well. So please stay in touch with us. You'll be receiving a follow-up email shortly with the recording and the link to the survey. We'd really be happy if you could complete the survey for us so we can continue to bring relevant content to our webinar series. All right, thanks everyone. We hope you have a wonderful day. We appreciate you spending the hour with us. Thanks, Gary.
Stay safe, everybody. Thank you so much for your time. Appreciate it.
Bye-bye.